but I'll actually take the time to get my slides together, and then I will introduce myself and my co-presenter, who is one of my mentees and a part of my lab.
Thank you, Will. And before you got on, Edwin was telling us about a talk he heard by Dean Schillinger yesterday where NLP featured very prominently. So this is really excellent timing.
Yeah, actually, that was really cool to see. I was on that team with Dean for that research. And just as a little brief overview for everybody else, and kind of apropos for the application of natural language processing, this was a study in which we were trying to use natural language processing on clinical text communications between physicians and their patients, through patient portals, in order to assess the level of writing complexity of patients and health literacy, writing complexity of the physicians and health literacy of the patients, and then develop algorithms to assist physicians to moderate their level of writing complexity to something that was more commensurate with the patient's health literacy, so that it would improve communication between physician and patient of complex health information. So welcome everybody. This is the second, I believe, in a series of methods course presentations for different skill sets and methodologies. And this one is specifically about the application of natural language processing on clinical text notes. Here today, we will present a user-friendly natural language processing tool of free text clinical notes that's available at UCSF. Two tools that we are going to particularly be focusing on are Immerse and cTAKES. And this is a co-presentation between myself, I am Dr. William Brown, and my mentee, Shivani Mehta, who is a Ph.D. student in the Department of Epidemiology and Biostatistics. And we'll both tell you a little bit more about ourselves. Like I said, my name is Dr. William Brown. I am an assistant professor in the Departments of Medicine, as well as jointly appointed in the Department of Epidemiology and Biostatistics. I am also the founding director of the Clinical Observational and Data Excellence Lab, the CODE Lab, as well as a associate director of the Bakar Computational Health Science Institute and the director of their of Diversity, Equity, and Inclusion for the Institute. I am also the vice chair of the new research data center that is being headed up by Edwin and Stuart Gansky and Kim Rhodes. Correct me if I'm wrong, Edwin. And also the implementation science lead for the Center for Digital Health Innovation, and particularly housed in the division. I'm particularly housed in the Division of Prevention Science as well, and am a co-director on its methods core, which brings us here today. I will also give my mentee and colleague, future doctor, Shivani Mehta, a chance to introduce herself as well. Don't see her on yet, but I'll go ahead and introduce her. Like I said, Shivani is a mentee of mine. She is a member of the Clinical and Observational Data Excellence Lab, as well as, hold on one moment. She texted me for the Zoom link. Stuart, if you could send her the Zoom link.
Will do.
And she is also a T32 fellow in our advanced data training for social and behavioral scientists. This is a 232 that I am a MPI on and co-director of in the Department of Epidemiology and Biostatistics with Maria Glimmer and Eric Prather. We'll go back to let Shivani introduce herself once she is able to. We'll give her a moment to introduce herself when she gets in or when her part of the presentation starts. So I also wanted to introduce the Code Lab specifically, which is at the heart of why we're giving this presentation. The Code Lab, our mission is to help researchers and healthcare workers contribute to create a learning healthcare system. I'll give you guys a chance to go ahead and look at what that means, but essentially that is an environment in which we are leveraging technology and informatics and a lot of these different data tools to have a reciprocal process of the data that we're collecting in real time with patients and with physicians, transforming that into knowledge and then applying that knowledge to improve healthcare. And that's essentially a learning healthcare system in a nutshell. And we accomplish this by developing innovative methods and tools for collecting data, educating researchers, students, and healthcare providers about these tools, which is, again, why we're here today, and then harmonizing data for new analyses. Also with our lab, we are deeply committed to improving diversity, equity, and inclusion at UCSF. So I welcome everybody to visit our lab and learn about some of our projects after this presentation. So the goals for the workshop today are: 1, learn about natural language processing tools for research at UCSF. 2, be introduced to user-friendly NLP tools available at UCSF, particularly EMERSE and the cTAKES tool. cTAKES is a service as well, and I'll tell you more about what that is. Of natural language processing for understanding social determinants of health and diabetes. We also want to help you guys through the process of getting access to these tools. We'll do that in the 3rd and last hour as well. And then we'll discuss any questions that you guys may have about the tools. We'll also stop between the different sections to answer any questions that you may have. And so our agenda for today is, in the first hour, we'll give an overview of natural language processing tools at UCSF. That will be given by me. And then in the 2nd hour, Shivani will be taking you through a use case presentation of how we've applied natural language processing to social determinants of health and diabetes. And then in the 3rd hour, we'll go through the access walkthrough, have a discussion about the tools themselves, and answer any questions that you guys may have lingering. So just to jump right into it, the first tool that I want to talk to you about is cTAKES. cTAKES, Apache cTAKES is known as, but just simply as cTAKES, is the Clinical Text Analysis, Knowledge, and Extraction System. cTAKES leverages a large data tool and resource called the Unified Medical Language System, the UMLS. And in a nutshell, the UMLS is a repository of different ontologies, control vocabularies, and knowledge structures that essentially tell you the relationship of one data element to another data element. So it'll say something like, you know, this data element is a, or this data element has a, and so that you understand, and so that computers can understand the relational nature of a tree branch of different data elements. And so cTAKES leverages the UMLS, a number of UMLS clinical vocabularies and ontologies in order to do concept-specific attribution of different references in clinical text notes. And so this diagram kind of briefly goes over that process. First, you'll start off with a HIPAA compliant secure notes database. This can be one that currently exists. UCSF has its own, and we can talk more about that. Or we will talk more about that. But if you've extracted clinical text and notes in your research study and in a HIPAA compliant way, and it's been de-identified, then you take the de-identified notes and then you enter it into cTAKES, which then goes over a tokenization process. This means breaking it down into several of its component parts of speech, personal title, dates, times, measurements, all this kind of stuff. So there are algorithms in it that break down the different tokens or aspects of the speech. Then it will leverage the dictionary that you choose from the UMLS in order for it to have some kind of knowledge base, so that it can take these words or tokens and move them into different types of medical concepts, and that's in this area right here, in the 1, 2, 3, 4th area right here. And then the enriched concepts get stored into a database and labeled as symptoms, diagnoses, locations, et cetera, with other different subdomains and things like that. And all this is done within an environment called the Information Commons. So a lot of this sounds particularly like complicated. You know, it may be a little daunting to go through this process of, well, what's the UMLS and what kind of level of programming do I need to be able to accomplish this? Well, this is where cTAKES as a service comes in. And so through the UCSF Data Center, there are resources at a cost, but resources where you, as the user and the client who wants to use cTAKES, can provide or designate a certain database of clinical notes that you want analyzed, and then submit that encrypted to the UCSF Data Center, and then they will take it and they will do the processing of it.
Well, while we're waiting for Will to reconnect, Shivani, we didn't get a chance to have you introduce yourself. Would you like to briefly tell us like who you are, where you're at in your program, and kind of what what your area of study is, the kinds of things that you're interested in? Thank you.
Yeah, of course. Sorry about joining a little late. I got confused with the Zoom links, but yeah, hi everyone. My name is Shivani. I am a first-year PhD student in the Epi and Translational Sciences program with the Department of Epi and Biostats. I'm also a T32 fellow in the data science training to advance behavioral and social science expertise for health disparities research. I'm also a GSR at the Code Lab and working with Will on natural language processing work in diabetes and opioids research, and have been actually using many of the tools that is going to be presented today. And then, as Will mentioned, I'll be talking about the use case example of the work we're doing using Immerse and natural language processing, and some of the work we just submitted to an AMIA conference. And that's just a quick introduction about me.
Great, thank you, Shivani. I just got a message for Will. He's trying to get back on, but it's not letting him. While Will is trying to get back on, Shivani, how did you get involved with this particular project, and what has been your role so far? Yeah, I know we're going to hear more about that in our second session, but just while we have the time.
Yeah. So I actually came from an health economics, outcomes research, and evidence-based medicine background. And then during my MPH, I started getting more involved in real world data and evidence, you know, teaching myself how to code in R and various other languages, and became really interested in bioinformatics work. And so I kind of shifted gear. And so while I was applying to the program, I also applied for this T32 trainee, and Will is a co-PI on that. And then, you know, Will said that he had some great projects and I could help, you know, him out work on it. And so that's sort of how I got involved. And then the work that I'm doing specifically for the NLP stuff in diabetes, I'll speak to more about it during the use case example.
Great. Thank you, Shivani. So Will, looks like we've got you back.
Yes, I am back. My apologies, everybody. As we would have it, my internet has literally shut down in my neighborhood. And so I am hotspotting from my mobile device, thank goodness. And so I can continue on. But yeah, the entire network in my neighborhood is down and out for the count.
Always have a failover plan B and C. Thank you.
Thank goodness I know how to hotspot from my phone. Let me plug in my phone so that it doesn't die on me, and we can get back to the presentation.
Thank you.
So essentially, what I was saying was, and thank you so much, Shivani, for introducing yourself. And so essentially, what I was saying was, so if the use of cTAKES and things like programming and new technologies and control vocabularies and the UMLS all are a bit daunting, we have a whole service that is provided through the UCSF Data Center in order to do the work for you. So this is kind of an example of how cTAKES work, and a couple points to specifically highlight are the text that it's focused on. So in here you can see where certain specific texts are highlighted, and then in various colors, and then are translated. And this isn't a one-to-one color matching in the moment, but you can see that the text is highlighted and linked to the actual location of the text itself. Then the domain from the controlled vocabulary or ontology that you're using is related to that specific text. The concept unique identifier, the CUI, is also provided for that, and that's also a part of the clinical vocabulary, and then the name of the vocabulary. In this case, they're using two vocabularies: SNOMED, systematized nomenclature of man, and RX norm, prescription normalization. So yeah, this is, and so yeah, so this is essentially a quick example of how cTAKES work. But again, if you want to learn more, you can go to data.ucsf.edu for access to the form that you fill out in order to request assistance. And I think you get 1 hour of consultation for free. Next, we want to go into the tool that we're going to be demoing and giving a use case example of later on, and that's the electronic medical records search engine, EMERSE. EMERSE is an open source software tool to search and browse notes data without any programming experience. This is one of the reasons why we really like this tool, because it has a very user-friendly graphical user interface. It was originally created at the University of Michigan and has now been integrated into the UCSF suite of clinical data services. Clinical notes are extracted from UCSF the UCSF electronic health record, EPIC, and are processed by software to remove 18 PHI elements. We'll talk about how that removal process happens and the automated NLP tool that is in charge of that. And then patients' records are assigned synthetic identifiers that maintain the link between notes and the patient's structured data in the de-identified CDW, which we will also be talking about briefly in the form of an additional user-friendly tool called Patient Explorer. So there's going to be a lot of different things we're going to go over today. So as I was saying before, there's a process by which the HIPAA-secured notes, again, that are acquired and approved by IRB, and it range from, there's patient emails, encounters, nursing notes, radiology, pathology, and other various types of notes. In the process of creating the filter algorithm, which I'll talk a little bit more about it, but this is our method for the automated de-identification of clinical notes. We created an algorithm. We used 25,000 manually de-identified notes as a knowledge corpus so that we could filter a de-identification software that could then automate the process of de-identifying all of these other notes. And so these notes go through the filter. Filter goes into the machine redacted notes database, and then into information commons. So a little bit more about filter. If you want to know more about it, there is a published article on exactly the different elements of the process, but I'm going to review some of those now. So the illustration of the filter algorithm starts off with the clinical note, which would be, over here in this area. Then there is a identification and extraction process. Then a whitelisting to keep medical terms and common English words salient, so that those don't get accidentally removed as well. And then there's another process to try to catch any adjacent material and to extract any other sensitive elements based on that adjacent material. And then the material that is whitelisted and the material that's been extracted are re-aggregated together back into the full clinical note. This is an example of that de-identification process. So here we have an MRN, and we have date, and we have patient name, date of birth information, other kinds of identifiers, and then other kind of words that also may allow for the post-identification of this patient beyond just your standard identifiers. And you can see that before we have all these elements in, and then after we give a synthetic patient medical record number, we date shift the data of the clinical note and other types of information in a randomized but still structured kind of way. And then the different elements that are identifiable elements are extracted. In some cases, you may find that some things that you wouldn't expect to get redacted do get redacted. And some examples are for over here, it was triage complaint, and it says brick fell, and then brick was extracted out. So though that's not a identifier, it's trying to understand the different elements that could be identifiable. And it's not a perfect system, but in order to do this on a large scale, this really speeds up the process. Filter is a tool that's actually available for use if you need to de-identify clinical text or other kinds of types of public health text. And you can find that at database.ucsf.edu as well through our GitHub. Throughout this process, Shivani and I will be working together to provide links to the different things that we're discussing into the chat box. And now I want to talk a little bit more about the process of the kind of information, the data flow of the clinical notes. And so the other thing that I want to highlight is that we have a general set of clinical notes. And then also, because of the times we're in, we have a COVID specific set of clinical notes. And these are UCSF patients who've been diagnosed with COVID. And so both systems start off with data from our Epic system, our Epic installation. They go through a process called Clarity, and that's also filtered through through our clinical data warehouse. And then those get translated into, get filtered from Clarity and our clinical data warehouse, which also has other types of data in it. Shivani will briefly talk about some elements of that structure and into general notes. Then it goes through the machine redaction process that we spoke about before with filter. And then it can be used by cTAKES or transferred into Immerse, which I'll show you a bit about later. And this is the de-identification process and workflow for Immerse and cTAKES. So you have our de-identification server that was in the previous slide. The note texts are loaded into metadata into the Mongo database. The de-identification algorithm is then run on the raw clinical notes, and then we get de-identified clinical notes that goes over into the consumer Mongo server, and then those are both filtered into cTAKES and Immerse. And then these are examples of different programming languages that allow you to interact with this type of information, with these de-identified clinical notes. I think the most accessible of which, or what people may be most familiar with, is RStudio. Here is a snapshot of what the Immerse website looks like. And so when you get access, which you all will at the end of this, I'll be approving all interested people who go through the process as we walk through access to the Immerse system, as well as Patient Explorer and a lot of the other tools that are available. It's all one process in order to get access to a myriad of different tools. And so you can see that we have the terms that so the temporary terms. So this is all connected to a database of over 2 million or over 2.5 million patients who and their clinical notes. And so this tool essentially allows you to add a term into Immerse, and then it will classify and identify which clinical notes have that term, and then give you more information about the patient that the clinical note is attached to. And then you can then use potentially a crosswalk in order to match or connect the patient unstructured clinical notes that you've extracted concepts from with their structured clinical data that you can find in Patient Explorer. This is a landscape of the clinical data that we have at UCSF. Everything above the red line are all identifiable data in all the different sources. We have some historic legacy data sets and our current existing data sets. They all go into the clinical data warehouse. Geocodes are also added in there. There's also images and clinical notes, as you can see. And then there's a lot, and all these lines kind of lead through this de-identification process that end up in this kind of cloud of services called the Information Commons. And so you can see in the Information Commons connected to the de-identified clinical data warehouse, we have Patient Explorer. We have the Image Commons, which we can talk about a different day. And then we have EMERSE, that has access to the machine redacted clinical notes. You can also use Python and R, et cetera, et cetera. So the other thing that I wanted to touch upon, and this is not a natural language processing tool. It is a search engine. So there is some, like low level language processing software that's driving behind it, but it's not a tool that's meant to understand the words in free text notes. This is a tool that's meant to be able to capture populations of patients based on various health criteria or clinical conditions. And so this is Patient Explorer. This is also a very user-friendly data tool. And Patient Explorer is a de-identified data set of structured clinical data from the EHR, from our de-identified clinical data warehouse. And it allows you to search the structured data and export cohorts of patients from the clinical data. And it has this source of data cohorts has nearly 4 million different patients represented in that. And because it's all de-identified, once you get access, you can immediately download the data as you explore the different patient populations under whatever conditions that you designate. So different types of ways that you can kind of search this database is through diagnosis codes, encounters, different types of labs, medications, different types of patient demographics, procedural codes, what types of providers they may have, or even different types of vitals. So as you can see, it's a very powerful tool. But in addition to that, instantaneously, it provides data visualizations and graphs for you that help you to depict or communicate the cohort that you just extracted. This is really helpful for papers and for reports and for grants. So as you can see, it's a really powerful tool. And again, one of the reasons why we're talking about this tool, even though it's not a natural language processing tool, is because in the exemplar that we're going to go in the use case that we're going to talk about later on, we are actually leveraging both Patient Explorer and the EMERSE tool together in order to run a comparative analysis on social determinants of health within diabetes.
Quick question, Will, from the chat. Is additional authorization required to access Patient Explorer, or is it you just have to be inside VPN?
So to start off, you will have to be inside of VPN in order to fill out the form to get access. When you utilize the tool itself, you will also have to be in VPN. So everything has to be done on the network. So if you do not, if you're not either on site or have the ability to VPN, you will not be able to access these tools, but also you won't be able to sign up for these tools either.
Okay, so you have to sign up. You have to sign up and be approved. Okay,
correct.
Great.
And we're going to go through that process at the end of this. And one of the tools that you will be gaining access to as a result of getting access to Immerse is also Patient Explorer. They've really streamlined the process so that you only have one application form to go through, and then all the things that are related to the de-identified suite of tools, or the tools of that are a suite of tools that are, give you access to the de-identified clinical data warehouse, are all in the same application. It used to be that you had to have an existing research study, and specifically for Immerse, there was a specific paragraph or a couple paragraphs of text that you had to include in your IRB or to make a modification to your IRB with this text. It wasn't super difficult because literally you just copy and paste this text, put into your IRB and resubmit for modification. But now you don't even have to do that because the clinical text notes that have been processed through a filter have now been IRB pre-approved and no longer need a honest broker for use. Do we have any other questions?
Yeah, there's another question from the chat from Kelly Taylor. Can you search this by provider or provider group, or is that masked?
You can't. I'm assuming that you are, well, if you're talking about either or, for Immerse, that is patient only clinical notes. And Shivani, please hop in and correct me if I'm misstating anything. And then for Patient Explorer, you can't specifically search a provider, very similarly to where you can't specifically search a patient, but you can search under a type of provider groups.
Provider type.
Yes.
Yeah, and to quickly jump in, so exactly. So you can search by provider department, provider encounter date, provider specialty, or provider type. But just to make of note, the provider encounter date has been date shifted because it is de-identified data.
New question, is there a difference between what we get from Patient Explorer and query from the de-identified CDW? The answer is actually yes. If you query this de-identified CDW directly through a interface called Ray, which we can talk more about in the Q&A session, using some of the more programming tools such as SQL through the SQL server, then what Shivani and I have found is that there is more information there and a few different other element types that are accessible when you query the de-identified CDW directly versus if you use Patient Explorer. They are currently working to minimize that difference, but some of those differences still exist. And they are fairly responsive. So if you reach out to the designers, developers, and data scientists at the Bakar Computational Health Science Institute, then they'll usually be more than happy to produce some kind of workaround in order to get you exactly what you need or walk you through the process. Do we have any other questions? Anybody can feel to unmute and speak, or continue to add in questions into the chat.
I have one question, Will. How live is the clinical data warehouse? Is it being continuously added to, or you know, is it a year in arrears and there are annual updates? What's the longitudinal history of the warehouse and how often data gets input?
I mean, there's so many different databases, and so sometimes I get them a bit confused. I know that the largest range is quarterly, every 3 months that I'm aware of, but I believe in some instances it's as regular as monthly. So it could be even more frequently than that, but I wouldn't feel comfortable saying anything more than monthly.
That's actually pretty good. We're at our 50-minute mark. We'll be hanging out, but please feel free to take a bio break and get some food or answer those really urgent emails and texts, and we'll reconvene at the